Bismillahirrahmanirrahim. Assalamu alaikum warahmatullahi wabarakatuh. Good evening to all the doctors who have come online for today's webinar entitled Abdominal Pain, organized by Dubai Pediatric Club in affiliation with NMC Specialty Hospital Dubai and Vitabiotics. Myself, Tawfiq Ali, Country Business Manager of Vitabiotics. So I'd like to start introducing Dr. Sohrab. Dr. Sohrab is the president of Dubai Pediatric Club, so you don't need any introduction after having so many webinars with Dr. Sohrab. So Dr. Sohrab will take you through the program. Dr. Sohrab, please.
Thank you very much, Mr. Tawfiq. Good evening, ladies and gentlemen. I would like to welcome all viewers from Dubai, UAE, GCC countries, and all over the world, especially India, attending our webinar. We have two eminent speakers. In short while, I'll be introducing them. Well, this program, this webinar is CMA accredited in the collaboration with NMC Specialty Hospital Dubai and sponsored by Vitabiotics. I would like to thank the country business manager of this company, Mr. Tawfiq Ali, who is always supporting us. I would like to take your permission to share my slides. Is it okay, Mr. Tawfiq?
Yes, doctor. Go to the presentation.
Is it okay?
Yes.
Mr. Tawfiq?
Yes, doctor. Go ahead, please.
Yeah. Once again, good evening, ladies and gentlemen. Welcome to this webinar. Well, as I mentioned, today's webinar is about abdominal pain and approach to abdominal pain in children. We have two eminent speakers, Dr. Muhammad Miqdadi and Dr. Diari Muhammad. In a short while, I'll be introducing them and I will tell you a brief profile of them. Well, we have two moderators, Dr. Kalpana Sengupta and Dr. Rajinder Joshi. I'll be introducing them also in a short while. They don't need introduction, everybody knows them. Well, there is a question for the audience, and now you just please see after 5 minutes, those who answer right, Mr. Tawfiq will announce and we'll give a token of appreciation to those who answer rightly. Of course, for 3 viewers who answer correctly, we will consider some token of appreciation. Welcome to Dubai, one of the most beautiful cities in the world. Those who have not seen Dubai, please, this is the best time to come and visit this beautiful city. Well, members of Dubai Pediatric Club, then in the beginning and now, all of them, on behalf of all of them, I'd like to welcome all viewers once again. Well, the members of Executive Committee, members of the Dubai Pediatric Club, Dr. Rajendra Joshi, the past president, Dr. Kalpana Sengupta, secretary of the club, head of the Department of Pediatrics at NMC Specialty Hospital Dubai, Dr. Rajendra Joshi is head of Department of Pediatrics in Prime Hospital. He's the most senior pediatrician. Dr. Diari Muhammad, he's our speaker today. Dr. Amir Toleimat from Emirates Hospital Clinic Dubai. Dr. Ayman Jondi, senior pediatric surgeon from Valiant Clinic and King's Hospital. Dr. Rafia Overa, well-known specialist pediatrician at Prime Medical Center, Jumeirah. She is the manager of that branch. Dr. Srinivas Pandari, the senior most specialist pediatrician at NMC Specialty Hospital Dubai. Dr. Leila Al-Bahri in Green Life Clinic, senior specialist pediatrician, and Dr. Khalid Rashid, senior specialist pediatrician at Dubai Police Associated Clinics. Well, about today's speaker, Dr. Muhammad Miqdadi is a consultant pediatric gastroenterologist at Sheikh Khalifa Medical City, Abu Dhabi, and Dr. Diari Muhammad, senior consultant pediatric surgeon at Al Jalila Children's Hospital, Dubai. A brief profile of our speakers in a short while I'll be telling you. Well, we have, as I mentioned, two moderators, Dr. Kalpana Sengupta, the secretary of the club, and Dr. Joshi, the past president of the club. Well, I would like to inform the viewers that the future Bpc events in February, on Friday, 18 February, we have one face-to-face physical meetings. An eminent professor of endocrinology, Dr. Magni from Italy, will be the speaker. This venue will be Intercontinental Hotel Dubai Festival City. The second webinar will be on 28 February at 9 p.m. This will be an online webinar. The topic will be different presentation of leukemia in children. We have eminent speakers from India and UAE. From India, Professor Amina Tehran from PGH and Digar, and from UAE, we have Dr. Hassan from Al Ain, senior consultant, infectious specialist, and we have also Dr. Al Baroudi, senior consultant pediatric hemato-oncologist from Abu Dhabi. Well, in March, we are planning to have a webinar on an approach to congenital heart disease with eminent speakers from India, Dr. Debadeta Mukhopadhyay from Calcutta, and from UAE, we have Dr. Mahmoud Al-Sufi, Dr. Muhammad Sulaiman, and Dr. Samir Sajwani. Well, details will be announced later. Well, once again, I would like to thank Mr. Tawfiq Ali, the country business manager of Vitabiotics. From beginning 2015, he is supporting us. He has been senior felicitated by the founder of the Dubai Pediatric Club. Well, briefly, I would like to give a brief history in few slides. Then I approach to, well, always start with Hippocrates. He said 460 BC, all diseases begin in the gut, and which is true. Well, this is a portrait painting, beautifully depicting the old days, what surgeons they were doing. And here it is written, surgeons did not start washing their hands before an operation until 150 years ago. At one time, they wore black coats, the better to camouflage their blood and guts that is splashed on them. Well, today the topic is the pain abdomen. We have gastroenterologists and many gastroenterologists also attending this webinar. Just in two slides briefly, I'll mention about the history. In 1805, Philip was in a German scientist and doctor developed a tube, which he mentioned it, Lichtleitner, means the light guiding instrument. This was the earliest description of endoscopy. Adolf Kussmaul, everybody knows him, Kussmaul breathing. In 1868, the well-known German physician developed a gastroscope. He perfected the technique on a salt swallower in the circus. Then Rudolf Schindler is considered as the father of gastroscopy. He and his colleague developed the semi-flexible gastroscope in 1932. And in 1957, Vasil Hirschkovich introduced the first prototype fiber optic gastroscope, just to remember them. And about the gastroenteritis, the first usage of gastroenteritis was in 1825. Before that, it was called typhoid fever or cholera morbus. Margot Scheiner, who in 1957 invented the biopsy tube that could be used to diagnose the intestinal diseases in children, particularly celiac disease, has been credited with initiating the emergence of pediatric gastroenterology as a distinct specialty. Just to remember them. Father of pediatric surgery, William Ladd, just to remember him. And this is interesting to know that in 1735, Claudius Ammian performed the world's first successful appendectomy. This was an 11-year-old child who presented with pain abdomen, and he swallowed one pin. But on operation, he found that there is an appendix in the hernia. The child had hernia and appendix was that. This condition is known as Ammian hernia, just to remember. Now, those who have answered now, Mr. Tawfiq, you stop receiving the answer. This gentleman you see here is Dr. Leonid Rogozov. He was a Soviet general practitioner who took part in the 6th Soviet Antarctic expedition in 1960-61. In April 1961, he developed appendicitis while he was at Novolazarevaskaya station. And being the only medical professional there at that time, he performed his own appendectomy under local anesthesia. See, you see him here. He is operating himself under local anesthesia. Just to remember. Well, now our hero, Dr. Mirdadi, briefly, I will introduce, give you his profile very briefly. Dr. Mirdadi is American board certified in pediatric gastroenterology, hepatology, and nutrition. He is division chief at pediatric gastroenterology, hepatology, and nutrition division as SKMC Abu Dhabi. He is adjunct associate professor, Department of Pediatric, College of Medicine and Health Sciences, UAE University, UAE. He is program director, Pediatric Gastroenterology Fellowship Training Program at SKMC, UAE. He is adjunct staff at Cleveland, Ohio, USA. Expert member of the FISPAGAN Council, that is Federation of International Society of Pediatric Gastroenterology, Hepatology, and Nutrition, Malnutrition or Obesity Expert Group. Dr. Mirdadi completed his fellowship in pediatric gastroenterology at Baylor College of Medicine at Texas Children's Hospital, Houston, Texas, United States. He held the position of assistant professor at Jordan University of Sciences and Technology in Jordan for 6 years prior to joining SKMC. He has more than 20 publications in peer-reviewed journals, and he is on the editorial board of few journals, including Gastroenterology, Hepatology. He is reviewer of the UpToDate.com. And second hero, Dr. Diari, very well known, both of them very well known. Just briefly, Dr. Diari is a senior consultant pediatric surgeon at Al Jalila Children's Hospital, Dubai. He is fellow of European Board of Pediatric Surgery and also fellow of Iraqi Commission for Medical Specialization in Pediatric Surgery. Dr. Diari is chairman of the Academic Affairs of Dubai Pediatric Club, as all of you know. His membership is member of Iraqi Medical Association, member of Emirates Medical Association. He is an international and local examiner for European Board of Pediatric Surgery. So I would like to request viewers to listen carefully to his talk because some of the questions are hidden there. He has numerous publications in scientific and peer-reviewed journals. He held many posts in Latifa Hospital, and since 2019 was head of the prevention and control of infection. Since September 2013 to September 2014, he was chairman of the hospital morbidity and mortality committee, and since June 2012 is a consultant pediatric surgeon at Latifa Hospital. Well, again, I'm ending with Hippocrates. Hippocrates said, first, do not harm. Do not, if you can't do good for the patient, at least do not harm. Beautiful city of Dubai at night with Burj Khalifa and view of Sheikh Zayed Road. Beautiful Dubai. Once again, I would like to request those who have not seen, come to Dubai. Thank you very much. Now I would like to request Dr. Mirdadi to start his talk. And I would like to request all viewers to write the question and answer box. After completion of Dr. Diari's talk, we'll start question and answer. Over to Dr. Mirdadi. Please start your talk. Thank you very much.
Thank you very much, Dr. Sohrab, for this nice introduction, and thanks for Dubai Pediatric Club for inviting me tonight, and thanks for Mr. Tawfiq for always being for us for educational purposes.
Dr. Mirdadi, I think it's coming as a slide view. So can you just jump to the presentation view?
Change it.
Yeah, hide presenter.
Yeah, okay. No, this is stop sharing. Can you see the
stop sharing? No, it's not coming now.
Okay, is it coming now?
Yes.
All right. Thank you all for coming tonight. And I was hoping this would be a physical face-to-face meeting, but however, we'll do the virtual and hopefully face-to-face will be soon. I really envy you in Dubai to have the Dubai Pediatric Club. I wish we have an active Abu Dhabi Pediatric Club. So Sohrab, can you accept me as a guest from Abu Dhabi to join the Dubai Pediatric Club? No, I'm just joking.
Oh, sure. You're always welcome. You're always welcome.
Thank you, Habib. So tonight we divided the talks between myself and Dr. Diari. We talk about abdominal pain in pediatrics, and I'm sure this is a very common problem, and I'm sure all of you, you see these patients in your daily practice. I will cover in my talk a general approach without going into the specifics about different medical conditions. I will highlight some of the typically missed causes of abdominal pain. Then I will highlight the important ones, the serious ones that we should not miss. My colleague, Dr. Diari, will talk to us extensively about the surgical diseases and how and when to refer these patients to get the surgical treatment on time. All right. Let's make sure it's moving. Okay. So I will share with you some of the tips in the history, in the physical exam, and the appropriate diagnostic testing. We all agree that history probably is the most important in diagnosing the cause of abdominal pain in these patients. So over the coming 25 minutes, I will talk about the GI and the non-GI causes. I will mention a little bit about the pathophysiology that's important to keep it in mind in order to reach the differential diagnosis. Then I will talk about the commonest causes of epigastric pain. Then we'll talk about the right upper quadrant. Then we'll talk about the mid to lower abdominal pain or the periumbilical area. Then we'll talk about the right lower quadrant pain. Then I will conclude by talking about functional pain. Dr. Sohrab Yasudni asked me to talk about COVID and abdominal pain and GI symptoms. And I will share with you one of the publications that my team at SKMC published recently. Okay, so the common causes of abdominal pain, by far probably the commonest is functional abdominal pain. Functional abdominal pain is probably a disease that's there. It's very similar to when we have tension headache. The pain is there, the symptom is real, but there is no true pathology behind it. Of course, we know gastroenteritis. Constipation is a very common cause, and I will mention to you some of the characteristics of that. Then we'll talk about peptic ulcer disorders. Then I will highlight a slide or two about lactose intolerance. Of course, whenever you see anybody with abdominal pain, you want to make sure you are not missing any of the serious causes like inflammatory bowel disease. I will mention about it. Then I will talk a little bit about liver and biliary disease. I will skip the parasitic infections, and Dr. Diari will talk to us about some of the surgical causes of abdominal pain like interception, appendicitis, obstruction, hernias. He will talk about that, and albolbolus also. Dr. Diari will mention that as well. Whenever I get a consult to see a patient with abdominal pain, the first thing in my mind, I want to rule out non-GI causes. As you know, the abdomen is crowded with many organs, so always rule out non-GI causes because the GI causes are easy to identify and easy to treat. Lower respiratory infections, lower lobe pneumonias are notorious for coming with abdominal pain and sometimes even with nausea and vomiting. And unless you are careful, you might miss a pneumonia in these patients. Also in the abdomen, we have the kidneys. The kidneys, they can get infected, they can have stones, they can get obstructed, they can have all kinds of problems. So always keep the kidney disorders in mind whenever you are looking about the case of abdominal pain. Also endocrine causes like DKA might present with abdominal pain and vomiting, and unless you are careful, you might miss it. Urological disorder, and Dr. Diari and the surgeon, they always teach us part of the abdominal exam is genital exam, and that's very important. Just do it very quick, make sure both testicles are down or in a male, in male or female, look if there is any masses, any hernia that's there, or any trauma or any sexual abuse. This is very, very important. And many of these patients, they don't present with genital pain. They might present with abdominal pain. Part of it, it's a referred pain. Part of it, they are shy. They don't know how to describe it. So please make sure urological and genital causes are ruled out. Gynecological causes, a fairly common problem, especially in teenage girls. However, it might happen also in other kinds of patients, even when they are younger. So pelvic evaluation is probably part of the assessment if you don't see an obvious diagnosis. HSP, henochal line purpura, it fooled me, and I'm sure it fooled most of you. Sometimes the child will present with abdominal pain before having the arthritis or the rash. So always keep it in mind. So keep the non-GI causes in your mind before you go to the GI causes of abdominal pain. Sickle cell is another manifestation of abdominal pain due to hematological lesions. So the pathophysiology, I'm not going to bore you with details, but we have to remember a few things about pathophysiology. The first thing, remember that in the abdomen we have the viscera, which is the viscus, which is the hollow organs, the intestine and the biliary tree and the others. So the pain that comes from the viscera is usually non-specific and dull in nature and cannot be localized. The patient will say, oh, I have pain on this side. It's all over this side of the abdomen, or all over all the abdomen. And typically these patients, when you ask the child or even the adult, where is the pain, he will touch it, he will push on it, and he will tell you it's deep inside. And that's very different than the somatic. The somatic pain is actually due to the irritation of the parietal peritoneum. If you remember your days from anatomy, this is the peritoneum that covers that comes anteriorly or to the sides in the abdominal wall. The somatic pains, like the patients who have an inflamed appendix, usually it's sharp, it's very localized. The patient will say the pain is right here in this spot. And when you try to touch it, the patient will guard. He will prevent you from touching it. Very different than the visceral pain. The visceral pain, the patient will hold it, will pinch, will pressure on it, while the somatic, he will not allow you to touch the area with the pain. The third kind of pain is the referred pain, that the disease is somewhere and the pain is felt somewhere else. Typical example of the referred pain is gallbladder disease coming with a shoulder pain, or orchitis, or torsion, or cyst, or what other kind of causes coming with the lower abdominal pain. Also keep in mind that also other causes of abdominal pain is abdominal wall, like trauma or injury, especially in young males who are trying to do a lot of sit-ups and other kinds of injuries. It might present with a specific pain in the abdominal wall, not inside the abdominal cavity. Sometimes every now and then we see retroperitoneal causes like skeletal muscles and malignancies happening there. The visceral pain that happens in the viscus, usually it's related to stretching. When there's distension, whatever the cause of the distension, gas, stool, whatever it is, that can cause pain. When there is inflammation in there, like an infection or an inflammation like Crohn's disease and others, or if there is ischemia. Ischemia is very painful. Please note that touching the intestine is not painful. Heat or others is not painful. This is why when we do biopsies to patients, they don't feel the pain. But if you put some gas in the endoscopy, some air there, with a distension, it's painful, or if it's inflamed, or if this is ischemic pain. You all probably remember from embryology class that the gut, the surgeons divide it into the foregut, the midgut, and the hindgut, or the lower gut. The foregut starts from the lower part of the esophagus to the stomach and to the duodenum. This is called the foregut. And the accessories are part of the foregut, like the liver, the biliary tree, the pancreas. Any pain in the lower esophagus, or the stomach, or the duodenum, or the biliary tree, or the biliary tree, or the pancreas, they present with epigastric pain. Although the duodenum is not exactly in the middle and the liver is to the right, but they might present with epigastric pain. The midgut it starts from the jejunum, the rest of the small intestine, all the way to the transverse colon. That's called the mid-gut. And the mid-gut pain usually comes with periumbilical pain. So any disease in the jejunum, all the way to the mid or to the transverse colon rather, comes with periumbilical pain. The hindgut, which is the last third of the transverse colon, the descending, Abpc Sigmoid, and the others, and the accessories to that, the urinary tract and the genitals, they come with suprapubic pain. So genital pain from whatever disease or UTI or others or hindgut disease, they might come with suprapubic pain. So epigastric pain for the foregut, periumbilical for the midgut, suprapubic for the hindgut, urinary tract, and genitals as well. We talked about this. Okay, we can skip it. We talked about the third pain. That was excellent. So abdominal pains, or probably any pain in general, it's modified by many factors, by the level of tolerance, by the development of the child, the psychogenic status of the patient, environmental factors, that all these factors might increase or decrease the sensation of pain. So in other words, if you see a child or even adult who says my pain is acceptable, does not mean his disease is mild. And the same, if he says my pain is very severe, does not mean this is a serious disease. So the level of tolerance is very dependent. You might see a patient with acute inflamed appendix who described his pain as being mild to moderate, and you might see a patient with simple constipation and describe the pain as being the worst ever in life. So it always depends on these factors that affect that. Let's highlight some of the important causes of the pains, and let me start with the epigastric pain. In the epigastric, it's the foregut, always esophagitis, gastritis, ulcer disease, H. pylori, pancreatitis, liver, and biliary tree. I'm going to highlight two important points about peptic ulcer disease, like gastritis, reflux, and ulcer. Usually the pain, again, in the epigastric region, sometimes associated with vomiting or nausea or both of them. Sometimes it might be referred to the back, like pancreatitis pain. Typically, it increases with food, and it's relieved when the patient is fasting. Always alerts me when I see somebody who awakens at night from sleep. Cannot sleep from the pain, but the other way around. He's sound asleep and he wakes up from the pain. This is usually an organic cause. If it fits in this criteria, it can be related to peptic ulcer disorders. It can be a positive family history. Gastritis is a very common problem that we see. Typically, it follows a recent viral illness. It can be any kind of a viral illness, even respiratory illness, especially if they have used non-steroidal anti-inflammatory drugs like ibuprofen or diclofenac like Voltaren or others. We have an entity called the stress gastritis, which is, I think it's very common. If you see any patient admitted to the ICU, that's an enough stress of the patient. Any patient on ventilator, he's predisposed to have a stress gastritis. Anybody who's sick enough, he might have this stress related. And sometimes this gastritis can bleed, and when they bleed, sometimes they can bleed diffusely. Typically, these patients, we diagnose them by history. Sometimes you need some investigation, and you can't start them on antacids or proton pump inhibitors. H2 blockers now, they are not available anymore. This is the famous H. pylori. This is a fairly common infection caused by the H. pylori. H. pylori was discovered by Marshall and Warren in 2005, and they got the Nobel Prize for their discovery, which has changed the history of medicine and surgery. As you remember, in the old days, surgeons used to do different kinds of surgeries for ulcer treatment, like vagotomy and selective vagotomy and highly selective vagotomy. These procedures are probably not done anymore, thanks to the discovery of the H. pylori. H. pylori, as you know, is a gram-negative bacteria. Usually, it's acquired in childhood. So most of us have acquired H. pylori early in life. It's oral or fecal-oral transmission. But keep in mind that most people with H. pylori infection are asymptomatic. So if you have a patient with abdominal pain and his H. pylori stool test or breath test is abnormal, yes, he has H. pylori, but does not mean necessarily that his abdominal pain is caused by H. pylori. Most likely, it's not caused by H. pylori. If it's caused by H. pylori, it can cause abdominal pain, nausea, vomiting, and if there is an ulcer or gastritis, it might be. But again and again, most patients, they are asymptomatic. In this publication, this is from up to date, 80% of the people who have H. pylori gastritis, they are asymptomatic. Yeah, 4 out of 5, they are asymptomatic. 15–20%, they might have chronic atrophic gastritis with nodular appearance, as you can see here. Some of them might go on into developing ulcer, but again, this is 10–20% of the patients, and less than 1%, they might develop a gastric cancer or mast lymphoma, as we know. So if you have 100 patients, most of them, they have nothing. They have nothing caused by H. pylori. It lives with them. Only 1% or less than 1% they have malignancy, and 20% they have gastritis or ulcer in the duodenum. Pancreatitis. Pancreatitis, I put the heading of the slide as easily missed or commonly missed. Pancreatitis is much commoner than what you think, and unless you think about it and you check the serum amylase and lipase, you will miss it, because the abdominal pain can be just epigastric pain, a little bit of vomiting, sometimes a little bit of fever, and that's it. Very easily to miss. Most of the causes are idiopathic. Sometimes it could be related to recent viral infection. We know mumps is the notorious, but all other viruses, even rotavirus, can cause that. And this is why the genital exam is part of the assessment of abdominal pain. Sometimes it can be trauma. The classic example of the trauma, a child riding a bicycle, he fell forward and the bicycle handle hits his gastric pain. Medications, there's a lot of medication that cause the pancreatitis, even if furosemide and others, they can do that. Recurrent pancreatitis can be caused by gallbladder stones, and this is not a rare cause at all in these patients. Familial hyperlipidemia can present with that, and also we have the familial or the genetic causes of recurrent pancreatitis. As a general pediatrician, if you see somebody that fits this picture, please check an amylase and lipase, although it will not change the management, but at least will give you an idea what's the diagnosis and maybe stop you from doing further investigations or giving antibiotics. And if it's recurrent, then probably it needs further assessment. There is a study done in the United States, they call the INSPIRE study, and they have screened people with children with abdominal pain and vomiting, and they found that many of these patients, they actually did have pancreatitis, and a treating physician did not think about it, and many times it can be missed, unfortunately. Moving on to keep on time, the right upper quadrant pain. Right upper quadrant, definitely you have to think about liver and biliary tree. Keep in mind that patients with liver disease like hepatitis, viral hepatitis or others, they can be anicteric, i.e. without jaundice. As you know, many of the patients with hepatitis A, they can be anicteric and no jaundice. They come with a little bit of pain, right upper quadrant, sometimes even epigastric pain, a little bit of vomiting, little bit of fever, nothing really obvious. And easily it can be a viral hepatitis. Keep in mind, viral hepatitis is not only A, there is A, B, C, and sometimes D, and also we have E. Hepatitis E infection is probably more common than what we think. Typically, it's a mild infection, not serious, except in pregnancy. Why do I tell you it's more common than what we think? Because many times I see patients with other liver disorders. I order for them hepatitis E IgG, and the IgG is positive. i.e. this patient had hepatitis E in the past and he was never diagnosed. So many times it gets missed. Of course, EBV and CMV can come. Also, the other kind of viruses can do that. But again and again, please remember that hepatitis can be without jaundice. Biliary tract disease, keep it in mind. Gallbladder stones, they can happen in children. In my group, we care for a large group of people who have gallbladder stones. Typically, it happens, I know, after the age of 40, but you know, at 40, there is like 10-20%, at 50, there's 30-40%. But at 30, there's, you know, maybe 10%, at 20, there is 5%, and so on and so forth. So it's not rare in children at all, especially I see it in patients who have been in ICU for a time, and in patients who have hemolytic disorders, patients with biliary disease like cystic fibrosis, and patients who have been on TP. All right, mid to lower abdominal pain, constipation by far is the commonest. I always tell our junior staff, everybody is constipated until proven otherwise. Constipation is a very common problem, very often missed, because you know the child at the age of 5 to 6 years of age, he's big enough to go to the bathroom by himself. He goes, he sits there for a while, nothing comes out, he comes out to the bathroom. Nobody will ask him, did you open your bowel or no? It's a kind of taboo, kind of shy. He doesn't know how to describe it, and he holds it again. I usually, when I ask the parents, I get a negative answer. No, he goes to the bathroom every day. Then when you do, for example, abdominal exam, or you do a plain X-ray, you will see he's full of stool. And then when you dig more in the history, he would say, well, I sat there for 10 minutes and nothing came out. So constipation, everybody's constipated until proven otherwise. Lactose intolerance, I think we spoke about it in previous meetings. It's not a rare cause of abdominal pain. Unless the parents are observant enough, they might not see the association between taking lactose and having symptoms. Patients with lactose intolerance typically starts around the age when they start going to school, 4 to 6 years of age. And their body is programmed in a way that you produce lactose till the age of 4 to 5, 6 years of age, then your body stops producing lactose after that. So the not absorbed lactose will go to the colon, causing all these symptoms. There's different ways to diagnose it. The ways I like it, first of all, you eliminate dairy products for a couple of weeks. The symptoms should disappear, or you can use some of the lactase drops. You drop it in the milk, or you take it with any dairy intake, and the symptoms will improve. You can do a breath hydrogen test and others if you want to do a little bit more fancy testing. Air swallowing, I'd like to mention that because again, this is one of the causes of abdominal pain and distension that oftenly missed. Typical story is a child with some behavioral problem, not developmental delay, just behavioral problem. And these people, they swallow air a lot. Normally, we as adults, we swallow air, or during eating, talking, laughing, you are swallowing a little bit of air. When it comes to excessive, it can cause a symptom. Typical story, the parents will tell you when he wakes up in the morning, his abdomen is flat, but when he goes to bed at night, his abdomen is distended. So this is usually can be diagnosed by history, and we need to help them, especially if they have a behavioral problem. UTIs, I'm going to skip it, but always keep it in mind. And many times the children will not tell you the symptoms. Please do a quick urine analysis in these patients to diagnose them. Right lower quadrant pain, I will leave it to Dr. Diari. He will talk about the surgical part, but let me remind you and remind myself of the mesenteric lymphadenitis. These patients, they come with abdominal pain, typically with or following a viral illness. And sometimes the pain can be significant. This is just a reactionary to a viral illness. A general rule of thumb, whenever you see these abdominal ultrasound reports saying there is a mesenteric lymphadenitis, okay. If the lymph node is less than 1 centimeter, probably you are fine. This is probably a benign reaction, does not cause any problem. If it is more than 2 centimeters, then you need to talk to a hematologist or an oncologist about that. If it's between 1 and 2, then that's the gray area. I would suggest to follow up this closely or do some testing. And again, you are looking for malignant changes. Okay. Functional pain. This is the Apley's definition. It's a school-age child, more common in females, typically non-specific pains. And it's a real pain. It's like tension headaches. And it's not related to constipation of eating or menstruation. Red flags. Okay, we talked about all the benign causes, but always keep in mind, functional pain does not happen in young children below the age of 4. If the pain is localized to an area, that's not functional pain, that's probably a pathological pain. Obviously, if there's failure to thrive or growth failure, if there is bilious emesis, you have to call your surgeon. If there is a fever with it, then you have to be careful. And Dr. Diari and his colleagues teach us that acute appendicitis does not cause high fever more than 38 unless it's perforated. So if you see a high fever, then you have to look at for other organic causes. If it awakens the child from the sleep, you have to be careful. Perianal disease, obviously, high ESR and anemia and blood in the stool are all red flags. This is the paper that myself and my team, we published in November, 2-3 months ago. In this paper, we reviewed all the children who were diagnosed to have COVID infection at our hospital, as you can see in Abu Dhabi, and we looked at these children specifically for the GI manifestations. Please note that 10% of them, they have abdominal pain as a presenting symptom. 11% they have vomiting or nausea. 18% of them they have diarrhea. So GI manifestations, whether pain, vomiting, or diarrhea, is common in children who present with COVID. In our review, a total of 27%, i.e. 1/4 of the patient, they have GI manifestation, which is more than what was published in the others. So children are more likely to have GI disease when it comes to COVID. And again, this is patients who are seen locally here in the United Arab Emirates. So, Mr. Chairman and dear colleagues, I'd like to conclude by saying the location of pain and detailed history can give you a clue to the most likely cause of the pain. You might need to do appropriate workup in these patients, but targeted workup, looking for specific diagnosis, and sometimes you might help you to do some imaging studies like X-rays, ultrasound. And when you do ultrasound, please keep in mind pelvic area to be included in the appropriate setting. One word about MRE, not IE. MRE is an MRI of the small intestine. This is a beautiful modality. I love it because it doesn't have any radiation, because it's an MRI technique, and also it gives you details of the small intestine in these patients. Endoscopy, whenever indicated, therapeutic trial like painkillers like paracetamol can be used appropriately. Laxatives can be used as well. With this, I conclude my presentation. I believe I'm on time. I'm looking forward to hear Dr. Diari's presentation.
Thank you very much, Dr. Miqdadi, for the excellent presentation, finishing in time. I'm sure there will be a lot of questions. Thank you very much. Now I'd like to request Dr. Diari, the senior pediatric surgeon at the Al Jalila Children's Hospital, to start his talk. After that, we will go for panel discussion. Dr. Diari, please.
Yeah. I can start.
Yes, please go ahead. I would like to inform that more than 750 people are following viewers. I would like to thank all viewers at this time. They are with us. Yes, Dr. Diari, please.
Okay.
You can hear me?
Yes, yes, your voice. You share your screen, please.
I am sharing. It's shared. You can see it?
No, doctor. I think your email screen is coming still.
There, you shared the wrong screen. You shared your email. Please share your presentation. Okay.
Just a minute.
Stop sharing and do it.
Just a minute. I did not share my email. How it comes? I'm sharing.
Yeah, can you just stop the sharing and restart, doctor? Reshare it.
Huh?
Stop sharing and reshare the presentation.
Okay.
So I'd like to request the viewers to write their questions. I'm sure there will be a lot of questions. After completion of Dr. Diari's talk, we'll start the question and answer session with Dr. Kalpana and Dr. Joshi.
Okay.
Once again, I'd like to thank Mr. Tawfiq for not sharing the video and allowing us to continue the discussion. Thank you very much, Mr. Tawfiq. Dr. Diari, please.
I am sharing now.
No, doctor. Still the same screen is coming. Can you stop sharing, doctor?
Yeah, dear, I am stopped.
Still coming.
Now I don't have anything, isn't?
I'll do one thing. I will stop sharing once. Okay. Now you start sharing again, doctor.
In the meantime, Mr. Tawfiq, anybody answered my question?
No, doctor. No one.
Yes, doctor. Yes, Mr. Tawfiq, it's okay?
No, nothing is sharing, doctor.
Oh. I can, it is there, I'm sharing it.
I think if you click on the center of the screen, that blue color share comes. By clicking on that blue,
Yeah.
Yes, yes.
But I cannot see it. So you are seeing?
Yeah, we can see it, doctor. But the presentation is not coming. Now it is coming.
It's coming now?
Yeah.
Yes, yes, yes.
Sorry, good evening, everybody. Sorry for the delay. Thank you, Mohammed, for this nice presentation. So, can you, I cannot see my, because this is there, this.
We are seeing your screen, Dr. Diari.
But your picture and my picture all in the middle of the screen. I cannot see myself. Half of the things is not there.
Maybe you have not started from beginning.
Okay.
If I may suggest, Dr. Sohab, we can do some questions while Dr. Diari fixes this.
Yes, Professor Khalaf Gargari, the president of Iraqi Pediatric Association, asked a question. I would like Dr. Kalpana, Dr. Joshi to start the question till Dr.
Okay,
now it is clear, doctor. I think we can move ahead.
Okay, so an international association for the study of pain defines pain as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage described in terms of damage. I will start my talk with a case presentation, which was just seen yesterday. This is an 8-year-old child attended emergency with 12 hours history of severe abdominal pain and repeated attacks of bilious vomiting. He was afebrile, no bleeding per rectum, abdomen cannot be examined due to severe pain. There was no distension. After giving morphine, there was a vague abdominal mass peri-umbilical region. So within the past 4 years, he had visited many hospitals due to the same pain, which has been settled with sedation. So 4 months back, he had the same pain episode and diagnosed as intussusception and reduced by contrast enema in another facility. All his lab investigations were normal. So this is his X-ray abdomen. You can see that there is a stool in the left side of the abdomen, and the right side of the abdomen, there is not too much of gas. And this is an ultrasound, which is then you can see the date, which is on 30 January 2022. That means yesterday. And there is a blind-ended structure with adjacent mesenteric edema and focal dilatation of the bowel. To be honest with you, the radiologist described that this could be a microdiverticulum or as internal hernia. When we took him directly to the OR, and then we found that there is a mass in the right iliac fossa, and it is covered with omentum, you can see, and there is the small bowel, all is in a sac, which cannot be seen properly. Then there is an adhesion to the right iliac fossa. After reducing the, releasing these things, and then I start, and it was an internal paraduodenal herniation. This is really a very difficult situation and a very difficult condition to be diagnosed. And you can see how I am bringing out the bowel. This needs an urgent and immediate surgery. You cannot delay because it might go to gangrene and volvulus. This is another view. You can see the upper side. There is a colon, and then this bowel is all herniated inside to the paraduodenal region. Okay, and then this has been repaired. Now, introduction: abdominal pain in children are different from those in adults and need to be treated with a greater degree of urgency than the equivalent conditions in adults. There are numerous disorders that are present with abdominal pain, ranging from a self-limiting condition such as mesenteric lymphadenitis to life-threatening conditions such as perforated appendix and midgut volvulus. Epidemiology of the abdominal pain: it accounts for approximately 5 to 10% of all pediatric emergency department visits. Surgery, just remember that surgery is only required in 1 to 7%. Non-specific diagnosis can be up to 15%. Causes: usually the causes are age and sex related and can broadly be divided into those occur in neonatal period, infant and toddler, and older children. It must be always kept in mind that inevitably there is in the common entities can be present atypically. Symptoms and signs: the presenting symptom and signs with abdominal pain in children are mainly vomiting, irritability, restlessness, and sometimes abdominal distension, fever, and bleeding per rectum, with some other associated symptoms and signs. Diagnosis: a careful clinical history followed by thorough physical examination is extremely important in reaching a provisional diagnosis, although this may be difficult to achieve, particularly in distressed child. That child, when he came yesterday, we were not able to touch him. So you cannot really take any, you have to properly examine him. Do not forget genital examination, please. Laboratory studies: laboratory, as Dr. Muhammad mentioned, they are helping you in diagnosis. When a patient coming with abdominal pain and a fever of 40 and white BC of 30, most probably this is not acute appendicitis. But sometimes when there is a perforated appendicitis, it might be more than that. Radiological studies: radiological imaging plays a key role in the evaluation and management of abdominal pain. Plain films: I like plain films really because it can give you dilated loops, it can give you gasless abdomen, it can give you perforations, fluid levels, it can give you the constipation, foreign body ingestion. Contrast studies for pediatric surgery, really it is a cornerstone and we are using it many times. Ultrasound for pelvic and right iliac fossa organs, it's very, very important. CT and MRI to a lesser extent, except in malignancies. So management, it might be surgical and non-surgical management. The surgical, you saw that laparoscopy and laparotomy are the main surgeries. So remember, opiate does not negatively impact patient care. Although physical examination findings can change after the admission of opiate, there is no evidence that this changed final management or outcome. It is not accepted as a patient to come to the hospital and be admitted and suffering from pain, and you are not giving painkiller, just afraid that it will change the diagnosis. It will not change, and it makes you feel better and for examining the patient. Red flags, as Dr. Mohammed mentioned, bilious vomiting. Bilious vomiting can be medical cause due to sepsis, due to electrolyte imbalance, but abdominal pain, colics with bilious vomiting, always alarming. Blood in stool, it's always alarming. Previous abdominal scar, that means he had a surgery, and he is coming with abdominal pain. Even if it is a flat abdomen, you have to call the surgeon. Recurrent visits to the emergency within 24 to 48 hours. Patient coming with a little bit of abdominal pain and fever, and you are examining him as tonsillitis. You are giving medication. Next day or 48 hours, he has to be a little bit settled. If he's coming, he is still vomiting, he is still having abdominal pain, then please admit him. Weight loss. Weight loss is really significant in patients with abdominal pain. Abdominal masses. Female gender, they have the gynecological problems. You have always to think of when a patient coming for abdominal pain, a male, by 12 o'clock, midnight, 1 o'clock, we are regarding as acute appendicitis and we are admitting him. But for female, we are usually asking for ultrasound before admission. So we have to understand that only a small percentage of abdominal pain have surgical causes. Age influence, this is my conclusion, let's say. Age influence, diagnostic possibilities. Abdominal examination with genitalia is critical. Do not withhold analgesia, please. Etiology may be intra or extra abdominal. Serial examination is essential. Particularly, it is important to be done, preferably by the same physician. If not, then usually we are saying to keep the patient for observation. Few hours change a lot of diagnosis. Definite diagnosis not always possible. Clear follow-up plan is important. If your patient, you are discharging him from the emergency, you have to tell him, if you are not settled, please come back. And when it comes back, that means there is something wrong. So, objective to understand the principal cause of surgical abdominal pain in children and to be familiar with the differential diagnosis of abdominal pain based on history and physical examination. If you are looking at this neonatal, toddler, and children, these are the most common causes of surgical abdomen in pediatric group, starting with the neonatal, necrotizing enterocolitis, obstructed hernias, intestinal atresia, spontaneous perforation. In older and toddlers, 9 months, 10 months, 1 year, mainly intussusception, obstructed hernias, microdiverticulum, midgut appendicitis, with ovarian and testicular. Again, in older children, it's the same. Added to that, the gynecological problem of female age. So necrotizing enterocolitis is the most common GI surgical emergency during neonatal period. It accounts 1 to 8% of all neonatal admissions. It affects 0.5% of all live births and 3 to 5% of low birth weights. The mortality rate range between 30 to 50%, with the highest rate among infants requiring surgery. You can see different presentations on different X-rays. Nematosis intestinale on the left upper, and free air in the right when we are doing the lateral decubitus, and there is a drain for drainage of the air. And these are different presentations of patients. You put, when the patient is like that, it is always better to keep him stabilized and to put a drain for them for 24, 48 hours to a little bit stabilized. And these are different perforations. Sometimes it is pan necrosis of the intestine. Malrotation with or without gangrene, intestinal malrotation defined as intestinal non-rotation or incomplete rotation around the superior mesenteric artery. It can be, as I mentioned, we like the plain abdominal X-ray. You see the left upper, you see all the small bowel is on the right side. And then when you are giving the contrast, there is no C cup of the duodenum, and all the small bowel is on the right side and the colon on the left. And you have different non-rotation, incomplete rotation, reverse rotation. We don't like to see the picture on the right lower with gangrene of midgut volvulus. Postoperative, whenever there is a scar, as I mentioned, you have to consider that this patient having intestinal obstruction when it is coming with abdominal pain, and please refer him to the surgeon for further action. Other causes of abdominal pain, you can see that perforated Meckel diverticulum, perforated acute appendicitis, and obstructed inguinal hernia in female. It's most of the time it is ovary, and in male it is usually intestine. And these are all presented with abdominal pain and vomiting. This patient, when we mentioned that sometimes we have a non-surgical management of surgical problems, for example, 8-year-old child attended with a huge abdominal mass, and it was a pelvic abscess due to perforated appendicitis, and you can see that's the bladder, and around it there is a big amount of pus. So this is a complicated acute appendicitis, which it's better to keep under conservative management for 1 week to 10 days with antibiotic and not to do the surgery. And you see this is the CT scan again. It shows a big amount of pus in the pelvic, but with the conservative management, it has been reduced and it's been subsided, and no need for appendicectomy. 10-month-old child presented with sudden onset abdominal pain, and you see blood in the pampers, and you see that there is a mass in the lower abdomen. And when we did the ultrasound, it is an intussusception, and contrast enema failed to reduce this, then needs surgery, and it found to be invaginated Meckels with gangrene of the bowel. 3 years old, when a patient is coming with abdominal pain, and you are not doing the X-ray, you might miss this one. And you see that this is a child, 3-year-old boy with abdominal pain for 1 week duration. And when we did the X-ray, it was a multiple magnet ingestion, which causes multiple internal fistulas. Recurrent abdominal pain, why we are saying the girls, they are really red flags. This patient, you can see, if you can see the date, it is in 2016, 8-year-old girl and vomiting for 3 days duration. When we did the ultrasound, it was a right ovarian torsion. And you can see that's the uterus and that's the right ovary, which is thickened, and it was torsion. So that time in 2016, this patient underwent right oophorectomy, which is nowadays, it is almost forbidden, and we are not doing oophorectomy, but at that time, 6 years back, it has been done. This patient, you can see the date again in March 2020, she attended again with left ovarian cyst. Then at that time, you know, the parents are really under pressure, and they are very irritable, the patient in pain, and they are scared of that. This is also, again, another torsion on the only remaining ovary. Then laparoscopic left ovarian cystectomy has been done. But again, in June 2020, she came back with another cyst in the same ovary. We said that we cannot every day to go in. Let's wait, maybe this is menstrual, maybe luteal cyst and this. But then in July, it is the same, and it is getting bigger. Then we have to go in again, and we remove the cyst, and we kept the ovary. 12 years, why we said you have to examine the genitalia. 12-year-old girl with 4 days history of lower abdominal pain. And this was every month she is having the same at the time of menstruation, but this was an imperforate hymen. again, 11 years old. This child, we remember him, he attended 2 times, attended the peripheral clinics, and they diagnosed as orchitis and epididymoorchitis. And actually it was a torsion left testicle. So please remember that hernias and genitalia are important. Hernial orifices and genitalia is important to be examined because of referred pain, and this one 11, 12 years, usually they are shy to say that it is in the scrotum. Usually they point to the abdomen. So if you are not examining the genitalia, probably you will miss some cases of this. Some rare causes of abdominal pain, which you will not see them frequently, like the first case we saw with the internal paraduodenal hernia. So this is a patient who is 2 years old, presented with severe abdominal pain and the inability to vomit. And you see his abdomen, how it is distended. And then when they did a CT scan, there is a almost a big shadow of the stomach, and there is a left eventration. So this is a secondary gastric volvulus, and this is his CT scan. You see the eventration on the left side, and the stomach and spleen, everything in the chest. Then when we open as an emergency, and it was almost volvulus organic organoaxial volvulus, and it was almost necrotic. We could save the stomach. It was, you see how it is dusky, and then on the right lower, this is the diaphragmatic hernia or eventration. Then we suture it. 10 years old boy presented with mild to moderate abdominal pain for 4 days. Usually if it is a mild and there is a little bit of fever, and ultrasound gives you a normal appendix, then it is better if you have a suspicion to go for CT scan. And this CT scan, you can see some shadow of a fatty shadow in the anterior abdominal wall, attached to the anterior abdominal wall. And this is a classical for omental torsion. And this is the omental torsion when I did for the laparoscopy, and it has been excised. A 2-year-old girl with sudden acute abdominal pain for 1 day duration. You see that this patient has been seen somewhere else, and they did for her some contrast study. The history is very important. Once we ask the mother, she says that this patient, we know her that spleen is not in the normal position. So with this sudden acute abdominal pain and the spleen is not in normal position, we say that this is a splenic torsion. And this is, you can see that the upper ultrasound, that there is the bladder, and on the upper side, there is a liver and the spleen in between of them. Usually, and you see the lower ultrasound, that's the bladder, which is with the mass there. And usually this is not the location of the spleen unless it is splenic torsion. And you can see this spleen, how it became torted. And you see all abdomen because the spleen was there. 9-year-old girl presented with abdominal pain and anemia. Why we say anemia? Weight loss for 1 month duration. Weight loss usually is not a good sign. You have to consider it. And looks pale, mild, right lower abdominal pain with a palpable mass. Palpable mass is also a red flag. And when we did the ultrasound, there is a mass in the right side of the abdomen. That's the CT scan will show the same mass. Unfortunately, this mass was adenocarcinoma, which is very rare to be in children, but always we were an undergraduate and it's a belly and love, always and right differential diagnosis of acute appendicitis is adenocarcinoma. Thank you very much.
Dr. Diari, for the excellent presentation. Really, all of us we enjoyed. I would like to thank all the viewers. 800 viewers are following us from all over the world. Thank you very much, Dr. Diari. Now I would like to request Dr. Kalpana, Dr. Joshi to join us. Once again, I would like to thank Mr. Tawfiq for allowing us to continue our discussion and not showing the video. And I'd like to request Mr. Tawfiq if Dr. Vikrant, our specialist radiologist, also is there to join us in case if there is any question. Dr. Kalpana, please.
Yeah, Dr. Vikrant is not online, doctor.
Okay. Please, carry on.
Okay. Good evening, everyone. Thank you so much, Dr. Mikdadi and Dr. Diari, for your wonderful presentations. There have been a lot of questions that are there that are being asked in the Q&A. First and foremost, Dr. Sohrab, Dr. Muhammad wants to know what was your question. So shall we just start with that? You asked a question and you wanted people to answer. So.
Yeah, the question was, I answered that this was the Russian general physician who operated on his own appendix when he was in the Antarctic expedition. So a general practitioner operated his own appendix on appendicitis under local anesthesia.
I think he used the mirror. He used the mirror to operate on himself.
So praise to Dr. Mikdadi.
Yes, sir. I think
Please,
I don't win.
Okay.
Dr. Kalpana.
Yeah, sure, Doctor. Dr. Joshi, you can start with the first question.
The first question is about the very common observation that whenever we ask for an abdominal ultrasound for abdominal pains, the report says there are mesenteric lymph nodes. So how important is the diagnosis of mesenteric lymphadenitis? When do you consider it significant and how do you manage it? Maybe Dr. Magdadi can answer.
Sure. Mesenteric lymph nodes is a very common finding in children. In general, the rule of thumb, but this is not 100%, but the general rule of thumb, if the lymph node, the largest one, is smaller than 1 centimeter, then probably it's benign. Okay? If it's more than 2 centimeters, you have to worry about it. This is in general. 1 to 2 is a gray area. Of course, it depends if the radiologist will tell you does it look benign or not. Also, that's another feature. If it is less than 1, probably there's nothing. You just, probably you can just ignore it and call the patient. If it is more than 2, I would suggest to refer him to a hematologist and probably do some workup like ESR, uric acid, LDH, maybe further evaluation, and get him evaluated for malignancy. If it's 1 to 2 and the child looks okay and you are not worried, then you might repeat it maybe in a month or 2. That's how I approach it. I don't know if Dr. Diari has a different approach to mesenteric lymph node.
It's almost the same. It depends on the number more than 5 and on the size. Yeah, exactly as you mentioned. And most of the time, these patients, unlike the appendix, they have higher fever. They are usually coming with 39, 40 degree of fever, and they are more, even the white BC, they are more high. So usually by this and the ultrasound can give you the diagnosis. And the follow-up, most of them, they are not coming back for follow-up, to be honest.
Okay. There's a question from Dr. Muhammad to Dr. Mikdadi. Since we have spoken about so many different etiologies of abdominal pain, there's a general question that when should a pediatrician refer a case to a gastroenterologist in case of abdominal pain? So if we can start with that. And
I think most cases, they don't need referral. Again, constipation is one of the very common causes. Again and again, every child is constipated until proven otherwise. And one of the suggestions by several societies is the therapeutic trial of laxative. You start them on an osmotic laxative, see them back in a week or 2. Most of the time they have improved. When to refer them? If you suspect inflammatory bowel disease like Crohn's disease or ulcerative colitis, I would suggest to refer him to us for evaluation. If there is a bleeding, definitely we need to see him. If there is a failure to thrive, then probably that's another indication to refer. So if there is any red flags, you refer them. Otherwise, the commonest of the causes, probably they don't need any.
Dr. Joshi, you want to?
Yeah, what is the importance of, somebody wants to know what is the importance of auscultation of abdomen in acute abdominal pain?
Dr. Diari? I think that's for you.
In acute abdominal pain, auscultation usually we are as a surgeon, we are not using auscultation for significant. It's for us, it's only significant when there is bowel sound is exaggerated or it is a silent. When it is a silent post-operatively, we are just waiting because this is a paralytic ileus-like. This is post-operatively. Pre-op, when there is usually the colic is more important than the, than the auscultation, and you are visible bowel loops. With colic, these are the main things. Sometimes there is exaggerated bowel sounds are more important than a silent or normal sound.
May I add, Dr. Joshi, Dr. Diari mentioned the importance of a plain abdominal X-ray, and I think that's an underutilized modality. Plain X-rays are very, very helpful. You can pick a lot of things in these patients, sometimes even clues to congenital anomalies. Surgical disorders can be picked that way, definitely foreign bodies. And I'm sure, all the audience here, how many times you order abdominal X-ray and you find a foreign body that nobody knew about. So I think plain abdominal X-ray is fairly helpful. Even in simple cases like constipation, when you see a lot of fecal loading, when you show it to the parents, they are more likely to be convinced that this is a constipation, and hopefully they are more likely to be compliant with the treatment.
Exactly.
Right. Dr. Hussain Naji has a question for you, Dr. Mikdadi. What is the approach to manage gallstones in a 10-year-old child with no precipitating factor, whether symptomatic or asymptomatic?
Good question, Kaplan. I think the first thing I would do is to look for the causes. The commonest of all is hemolytical disorders, hyperlipidemias. This is the most likely cause. Congenital anomalies and others are there, familial is there, but typically the past medical history is obvious. So I will do a workup for hemolysis. I will do a lipid profile. If these are both negative and a child is asymptomatic and never had an episode of acute cholangitis, then probably I will just observe him and watch him. If he is symptomatic or have episodes of cholangitis, then the role of surgery becomes more obvious. This is another indication probably to do a plain X-ray. I will do a plain abdominal X-ray in this patient, looking if the gallstones are calcified or not calcified. If they are not calcified, there might be a role of orthodeoxycholic acid also that might help to dissolve it. It might. If it's calcified, then that's probably too late, and ortho is not gonna
work. Okay. Actually, he also has a question for Dr. Diari related to appendicitis. How often is it picked up by ultrasound at your center? Before that, I just want to know, when we were undergraduates, I think we were taught that it's a clinical diagnosis. And now more and more we are relying on radiological investigations. So what is your opinion about that?
Exactly. We are usually saying, but with the clinical diagnosis, we have a false negative appendicitis. High rate, almost we're reaching to 20% of negative appendicectomies. Nowadays, internationally is 1 to 5% with the ultrasound and CT scan and these modalities. To be honest with you, ultrasound is very, very good tool for diagnosing acute appendicitis when you have a suspicion. In our Latifa, it's more than when we were in Latifa, because just newly we are getting in Jalila. So it is more than 95%. We are keeping the CT scan for those obese or when we are suspecting and, they cannot diagnose it, but we are still clinically suspecting acute appendicitis. But more than 95%, we are sure that our radiologist can pick up. Yeah.
Okay.
May I interrupt? One question, Professor Khalaf Gargari, President of Iraqi Association of Pediatrics from Iraq, had asked about terminal ilitis. I'd like to request Dr. Kalpana if you raise that question, because that was the first question I think
he has written, he wants to ask about terminal ileitis in post-COVID patients.
Kalpana, you and Khalaf are troublemakers here. Terminal ileitis. The differential of terminal ileitis is a big one. It might be a simple infection. Any probably bacterial gastroenteritis can cause that. Also, it can be Crohn's disease, which is not rare at all, or it can be TB, or it can be others. Then I think my approach to patients who had the terminal ileitis by an imaging, whether it's an ultrasound, CT, or MRI, I will rule out infections. I will look at the past medical history and current history. Does it fit with the Crohn's or not? If I ruled out infection and it fits with the Crohn's, then he needs an endoscopy to confirm or rule it out. If it looks like an infection, and that's not rare at all, I will just probably repeat that imaging or do an ultrasound or MRI, not to repeat the CT, too much radiation, probably in 4 weeks or so. And many of these patients it resolves, and this was just a simple infection.
Okay. Dr. Joshi?
Yeah, there is a question for Dr. Diari from Dr. Muhammad Husni. He's asking how common is sigmoid volvulus in children, and can it be treated with solid endoscopy?
Yeah, it is rare. We saw sigmoid volvulus in a CP child when they are usually having a lot of loaded colon, and usually we saw it in only CP children. With the flexible endoscopy and with enema, yes, they are reduced many times. But if not, then we have to interfere surgically, either to do resection or just to detwist it.
Yeah. And Dr. Diari, you can just put a rectal tube and deflate.
Yes.
Because it's a top urgent. If the endoscopy is going to take time, I'll just put.
Yeah, by enema. I said by enema. Then we have.
Yes. The other diagnosis that you stressed a lot about, Dr. Mikdadi, was pancreatitis. So, is it different from pancreatitis in adults, or do we see similar, like progressive or recurrent episodes? Is it in any way different, clinical presentation or the course of pancreatitis in children?
Yeah, the pancreatitis in children is different a little bit. The pain is non-specific, usually epigastric. In older patients, you see the classical one, which is radiating to the back, all these things. But typically, no. How do I know that? When I see a patient who comes in later on with the diagnosis of chronic pancreatitis, if you go back to the history, you will have repeated episodes of non-specific abdominal pains, a little bit of fever, a little bit of vomiting, lasted for a couple of days and went away. Probably this was repeated episodes of acute pancreatitis in the past. Yeah, so it's less classic in children than adults.
Okay.
The other question is about this familial Mediterranean fever presenting with abdominal pain. What is your experience and how do you manage that?
Okay, FMF or familial Mediterranean fever. Typically, the background is Mediterranean. That's the typical. And usually they come with repeated episodes of serious pain, many times thought to be surgical. Many of these patients, they have their appendix taken out and they were seen by a surgeon because usually it's a vasculitic and they come with a peritonitis-like picture, rigid abdomen, and any surgeon will see them, they will think this is a surgical disease. So sometimes it can be associated with other psoriasis like arthritis and pleurisy and chest pain. So that's the typical presentation. Diagnosis, it's clinical plus a genetic test. However, you have to keep in mind that people from the Mediterranean region, around 10% of them, they carry at least one mutation of FMF. So having one mutation does not necessarily mean you have FMF. Typically, the affected patients, they might have homozygous or two heterozygous mutations of FMF. Colchicine can be used as a therapeutic trial, and most patients with FMF, they should respond to colchicine. However, one of the side effects of colchicine is abdominal pain. And the way to give colchicine, you start with a small dose, and then you titrate it up every 2 weeks or 4 weeks. If you start with the therapeutic dose, they will develop abdominal pain as a side effect of colchicine, not from the
Dr. Mikdadi, Dr. Jamal Aldin Hassan wants to know what's your opinion about lactose drops that are available to be given for colic in infants and those children who have lactose intolerance. And there was another question regarding the dose by another doctor.
Lactose and lactase problem. If you think this patient have lactose problem, lactase deficiency, then lactose should help in these patients. Lactase can be given either at the beginning or the middle of the meal, and some of the forms, the drops, they can be added to the actual milk or to the cheese or the yogurt. Infantile colic, they might have lactose, but typically no, it's not a lactose problem. For the simple explanation that, you know, breast milk is full of lactose, so that's not big. However, if you have a patient with suspected lactase problem, like after a gastroenteritis, after an insult to the villi of the intestine, like somebody with sepsis, somebody with the hypovolemic shock and others, yes, it might be used. The dose, you know, it depends how many international units there. Usually it's written on the box. You start with a low dose and you might titrate it up. Keep in mind that milk has the highest lactose level, while, for example, dairy products, they have less, and cheese, it has less. Ice cream has a lot of lactose, of course. But there's no dinner tonight, what to do?
There's another question, doctor, who wanted you to give some more details on infantile colic in relation, like you've spoken about lactase. There are a lot of reports, a lot of medicines being promoted, say, for example, probiotics. So what is your opinion about their role in infantile colic? Well,
infantile colic is a little bit outside tonight's presentation. However, the etiology of infantile colic, nobody really knows. Is it microbiota? It's different. Is it a protein allergy? Is it a carbohydrate problem? Is it related to the fat, SN2, and all these things there? So it's a bit outside this topic. Let's discuss it in a different occasion.
Sure. Yeah. I think there's another, people want to know more about acute pancreatitis. There's another question asking, what is the management in children? Is it surgery in pediatrics, or what is the management plan if you come across a case of acute pancreatitis?
First of all, keep the surgeons away. Don't call any surgeon for pancreatitis. That's a joke. In mild pancreatitis, it's usually symptomatic treatment with analgesics and antiemetics and fluids and rehydration. One thing not to give in pancreatitis is probiotics. There was a study in the adults, and they found that if you give probiotics, they might have more necrotizing enterocolitis. Severe pancreatitis needs to be admitted to the ICU. They are more likely to have sepsis and multi-organ failure. These patients, they need IV antibiotics and they need maximal support. Surgeons, they don't like to touch anybody with pancreatitis because it's very difficult to resect and very difficult to even suture it or anything, except in the worst of the worst when it's necrotic and it's like the patient is really miserable. Other than that, no. But again, I think it's important to diagnose it because it will give you the etiology, will stop you from investigating the patient, and if there is the appropriate family history, then you might diagnose recurrent pancreatitis or chronic pancreatitis.
Okay.
There is a question for Dr. Diari on acute appendicitis. What is the role of Alvarado scoring? Are you using it in pediatrics or it's only for pediatrics?
Actually, we are not using it. We are not using it. We are depending mainly on the ultrasound and imaging. And Alvarado, you know, it's honestly, it is difficult to use it in below 5 years of age and 4 years And most of them, when they are coming, they are perforated. It's not in a state of to diagnose or not to diagnose. And as a score of 10, when they are saying below 5, that means it is you rule out. Above 7, it's rule in as an acute appendicitis. We are depending mainly on the clinical and radiological, ultrasound mainly.
Yes.
The question for
Dr.
Dr. Miqdady is about abdominal pain as a presentation of migraine, abdominal migraine. Do you still diagnose it, and what is the treatment?
Yeah, abdominal migraine, Dr. Dushi, it's a diagnosis. Probably it's similar to the regular migraine that we know. Typically, these patients, they have recurrent episodes of abdominal pain, and in between these episodes, they are totally fine. It can be associated with headaches. Typically, there is a positive family history of migraine. It's a kind of a diagnosis of exclusion. So you have to rule out the other common causes of abdominal pain. Typically, it's in females, usually in teenager females. Their lab investigations and radiological imaging should be all normal. Their growth should be normal. And again, there is a strong family history of migraine in these patients. In these patients, the treatment, there are several kinds of treatment, including cyproheptadine, which is an antihistamine. Other people use propranolol, which is a beta blocker. And sometimes amitriptyline can be used as well.
And there are a couple of questions relating to H. pylori, starting from the incidence of H. pylori gastritis. Another doctor has asked whether it is contagious and is it preventable? So
it's contagious, yeah, definitely. It's fecal oral or oral. Is it preventable? Yeah, hygiene and cleanliness is very. This is the way to prevent it. But again, 80% of the people with positive H. pylori testing, they don't have any symptoms related to that. I.e., when you see somebody with H. pylori and abdominal pain, it does not necessarily mean that the abdominal pain is not caused by the H. pylori. And many times we see this, somebody with abdominal pain, H. pylori is positive, you get the treatment for the H. pylori, but the pain does not go away. This means that he has some other cause. Again, constipation is probably the commonest.
but how will you pick and choose the cases you would want to treat for H. pylori? Because there is a little bit of confusion regarding the tests that should be used and the cases that should be treated.
Yeah. The general rule of thumb, if you test for H. pylori, you should be ready to treat. If you don't want to treat it and you don't think it's related, don't test for it. The problem, Dr. Kalpan, is that if you find H. pylori, whether in the stool or in the breast test, the WHO has classified H. pylori as a carcinogen because almost all of the cases of gastric cancer are caused by H. pylori. But the reverse is not correct. Most of the cases of H. pylori do not cause cancer. But if you find an H. pylori, you cannot just ignore it as a carcinogen. When to treat it for sure? If it is symptomatic, giving them gastritis, ulcer, bleeding, any of these things, you should treat. If there is a family history of gastric cancer, you should treat. Other than that, is debatable. You can decide to treat or not to treat. However, if you tell a patient, listen, you have an H. pylori, there is a risk 1 in 10,000, it might change to malignancy. You want to take a treatment? Of course, the patient will say yes, even if the risk is really minimal and, you know, statistically should not treat. But if you tell the patient there is a 1 in a million risk of cancer, of course, they will get the
Okay, thank you.
There is an anonymous attendee who has asked that there is a 3.5-year-old child who comes with abdominal pain and gets relieved with a placebo. What do you consider that to be? And how early you can see the functional abdominal pains?
No, functional pains does not happen before the age of 4. The minimum is 4. So typically it's school-age children, 6 and above. The response to placebo, this is well described in the literature. Even people with myocardial infarction, if you give them placebo, some of them, they will respond. because it works in your endorphins and your neurotransmitters. So the response to placebo does not mean this is not organic.
There's a question related to the use of anti-spasmodic agents. So would you like to comment on it?
Well, I don't typically prescribe it, and I don't like it because it makes your stomach more, your intestine rather, atonic and lazy stomach, and it will worsen the constipation. Plus the other side effects like urine retention, which causes again pain, feeling of thirst and dryness is that. So typically I don't use spasmodics.
Okay.
I don't know if the surgeons use it. Do you, Dr. Yari, do you use spasmodics?
No, at all.
Yeah.
Not at all. Okay.
Not at
Yeah,
all.
paracetamol.
Usually I'm telling to don't give Infacol and these things, you know, to the parents when they are coming with infantile colic, they are saying we are giving and these things. They are causing more distension and more tympanic abdomen because of like atony of the intestine. Yeah, I do agree.
Yeah. Okay. Can bilious vomiting be seen in a non-surgical condition? One of the attendees has asked.
I mentioned in septicemia and in electrolyte imbalance they might have. In paralytic ileus, they are vomiting only bilious. You know?
Yes, right.
But if I see a bilious vomiting, I'm calling my surgeon for sure. Let him say it's not surgical.
It's not surgical. Yes, that's okay.
Dr. Anas Salabi wants to know how reliable is stool calprotectin as a marker of IBD?
You have to come to the Sharjah University Congress in 2 weeks. I will talk about fecal calprotectin. I will talk about fecal calprotectin in IBD, and I will talk about Dr. Yari about fecal calprotectin in predicting necrotizing enterocolitis.
Good.
So we'll give you some suspense till the Sharjah conference.
Sure. Dr. Jamal Aldin Hassan, I think this is a very specific question to Dr. Diari. When to start oral intake for 1 post-op perforated appendix and 2 post-op intussusception surgery?
Now, in perforated appendix, we are starting the same day unless it is really peritonitis with abdominal distension with, you know, paralytic ileus. That time we even put an NG tube and we are waiting till it clears. Otherwise, as a perforated appendix, you can start on the same day within 4 or 5 hours. For intussusception, if it is, let's say, hydrostatic reduction, we usually, if it is overnight in the morning, we will start. If it's in the morning, at night, we start. If it is laparotomy and manual reduction, the same thing on the same day or night, we will start. If it is resection anastomosis, 3 to 5 days because of the anastomosis. It's like that.
Right. And what percentage of cases of intussusception would, you know, direct open surgery be required?
Most of the time, almost about 85%, it will can be reduced by the hydrostatic air or contrast, and about 10 to 15% needs laparotomy, and most of them will be reduced manually, and few percentage needs resection anastomosis.
Dr. Diari, is it still a time limit between the symptoms and when you can reduce it hydrostatic? It used to be like, I think, 48 hours, or that's not valid?
No, actually no, because the progress of intussusception is not depending on the, you know, you never know when it happened. But sometimes you need it for the diagnosis, and sometimes if the patient is really sick and lethargic and this, you need rehydration. But if there is no perforation, so there is no contraindication. If you see the perforation or air under diaphragm or pneumoperitoneum, then this is the only contraindication. Otherwise, you can proceed as a diagnostic and then as therapeutic if it's okay.
Regarding testicular torsion, Dr. Tariq has asked how early should they be operated to, you know, obviously if you have diagnosed, you'll operate immediately, but to save the testes, or beyond what point if they present late to you?
The earliest you see it, don't waste time. Testicular torsion or testicular pain is almost always surgical till proved otherwise. it took almost about 20 minutes to explore and to give the diagnosis or to treat. There are literature shown after 36 hours, still there is some viability of the hormonal, let's say, cells. So it is better not to excise and remove it. To keep it is much better. The worst scenario will be an testicular abscess, and then you can at that time drain it. But usually we are not removing.
Okay, and what is the role of Doppler? You are doing Doppler for these?
We are, because it is in-house and there is a radiologist in-house, but it will not give, unless, for example, we have ultrasound, we are diagnosing hydatidov morgagni or testicular appendices. When the appendix, when the test is completely normal and you see an avascular dot at the pole of the testis, at that time you might treat it conservatively if we are sure. Otherwise, surgical excision, because it will reduce the pain and it will reduce the analgesia.
Okay.
There is a question about irritable bowel syndrome in children and how to differentiate it from the functional abdominal pains. Dr. Mikdad.
The definition of irritable bowel, Dr. Joshi, is abdominal pain with alteration of the bowel movement, whether it's a constipation dominant or diarrhea dominant. Typically, children, they don't have irritable bowel. They have what's called the functional abdominal pain or the recurrent abdominal pain or the benign abdominal pain, if you wish. Typically, the definition of functional abdominal pain is not related to bowel movement. However, in teenagers, you might see IBS and IBS-like picture. But again, it's a diagnosis of exclusion. I would be careful before labeling somebody with that. Probably I need a little bit more history, good physical exam, and some investigation before we label them as IBS.
There's a question about abdominal epilepsy and how to differentiate it from abdominal migraine.
Abdominal epilepsy, it's rather rare and difficult to diagnose it. Typically, you need to do an EEG during the episode of the pain and to see if the symptoms are, when the symptoms happen, there's an abnormal EEG. So that's a bit a rare diagnosis. I think a neurologist will be able to answer more than me.
Okay. Dr. Ali has asked how to manage recurrent abdominal pain. So now acute abdominal pain you have probably covered with most of the common scenarios. But if a child keeps coming to us with recurrent abdominal pain, what would be our approach? Or maybe from both the speakers, what you would like us to definitely do and not miss?
From a medical point of view, recurrent abdominal pain, to me, it's constipation until proven otherwise. So I will make sure he's not constipated. I will treat his constipation, do a screening labs. Again, it depends on the age and the presentation. Urine analysis is part of it. Pelvic imaging is to be considered in the appropriate clinical scenario. Again and again, as Dr. Diari mentioned, a genital exam is very important. You don't want to miss any genital anomaly there. And then accordingly, you treat. Most of these patients, they are constipated.
Yeah, constipation is very common. And I think after these last 2 years of reduced activity in no schools, we are seeing great many people, children coming with this kind of problems. Once you have treated and it's relieved, there was a question regarding how long to continue the treatment for constipation.
Well, I can share with you my daughter here. She had abdominal pain and she told me, and she swore to God, she does not have constipation. And she felt like, quote unquote, there is a mass inside. Long story short, she's constipated. That was seen by the X-ray and confirmed by the ultrasound as well. So we have to put her in laxatives. Typically, the laxatives, you have to give it for several months. I tell my patient at least 6 months of treatment to allow the colon to get smaller with that. It does not happen after a week or two. No, it has to be rather several months of treatment.
Yeah, so that counseling is important because parents generally tend to stop it. And what is the advice regarding diet, diet and constipation?
Well, diet, a well-balanced diet with good amount of fibers and all that, it can help. However, I don't think it will treat the constipation. I think it will prevent. It will help in the treatment, but cannot be used alone for treatment.
Right. There's a question from Dr. Ahmed. How will you differentiate abdominal pain in thalassemia being due to Yersinia infection or due to acute appendicitis?
Dr. Diari or?
Yeah, doctor. Either of you can answer.
Answer here.
Correct me if I'm wrong. Yersinia, I'm not sure if we see much Yersinia in UAE. Yersinia, I think it happens in cold weather. Is that right? And Yersinia, it comes with the right lower quadrant.
Yes, it's one of the differential.
Yeah.
One of the differential diagnoses.
Yeah, the question is from Iraq, doctor.
Yeah. So in cold weather, yes, you might get it. People traveling overseas. I saw a patient, I think he was in Pakistan, he got that. So it's one of the differential. Yersinia can present with acute appendicitis-like picture. Usually they have more fever, and typically in UAE they have a history of trouble.
When we are doing the ultrasound, if the size, diameter of the appendix is more than 6 millimeters, 7 millimeters, with discontinuity of the mucosa, with sometimes air in the lumen, sometimes fecalith in the lumen, these are the signs of acute appendicitis, and some fat strands, these are all by the ultrasound. Otherwise, there might be worms in the, and probably you saw some videos, there is worms in the appendix causing an acute appendicitis. There is a fecalith in the appendix causing acute appendicitis. So these are all can be. By itself, appendicitis is a sort of infection. So it might be just acute appendicitis due to the infection rather than due to obstruction or stone.
May I interrupt and ask one question, Dr. Kalpana?
Yes.
Dr. Mirwal, we see many, parents, they come, when child is having pain in the abdomen, they attribute it to worm infestation. No. Does it cause, this worm infestation cause pain in the abdomen? Which one causes? And which one to be treated, or if at all it causes pain or not? Because it's a common question by parents.
Yeah, yeah, definitely. Giardia is not a typical worm, though. It's a parasite. Giardia can present with non-specific abdominal pains, softer stools, typically not diarrhea, typically with history of travel. Worms like Ascaris and others, I don't think I have seen much in UAE. I don't think even I saw any here, but until in tropical countries, I think they see it. Entropius vermicularis, typically it's non-specific abdominal pains. Perianal itching is the prominent feature.
Right. Dr. Mohammed Husni has asked, is there any association between gallbladder stones in children and subclinical hypothyroidism?
I don't know.
But this question, Dr. Kalpana, how to, Dr. Diari, I have a patient, Dr. Diari knows how to follow the gallstone in children. Those who have gallstone, once in a while they get pain, and how to follow them?
Yeah, as Dr. Muhammad mentioned, if you rule out the hematological causes, you rule out jaundice, cholangitis, infection, acute cholecystitis, then we are doing it yearly, an ultrasound just for, satisfaction of the family. If it is a solitary big stone more than 1 centimeter, then we are really more happy because there is no escape through the cystic duct. When it is multiple and small, then we are really scared because sometimes they might escape to the common bile duct and causes an obstructive jaundice. Yeah. Otherwise, there might be some biliary colic with it. So they are presenting with the pain due to that biliary colic. Yeah.
Thank you.
Dr. Diari, that case you presented with the pelvic abscess, lot of pus with appendix, you said treated conservatively.
Conservatives, completely.
So classically, pus anywhere in the body needs to be drained. Does that not hold true here?
If the patient is febrile and this it is loculated and it is and doesn't need any cause, does not need let's say peritonitis, and it is just localized, by antibiotic it will go. And I think I remember a few years back, maybe I presented a complicated appendicitis, more than 15 cases, which can be treated completely without any intervention. Actually, I was not, I did not like to put another patient, which we treated, and then he came with, again, recurrent acute appendicitis with perforation, again, treated conservatively. One day I will present it for you. It didn't need any appendectomy.
No, because we had a similar case and the child went into sepsis and
that's
DIC.
Different. Yeah, that's different. That's different. That's different. And then you have to, because when it's going to DIC and peritonitis, then the fever will not subside. But when the patient, there is no fever and the patient is in full oral, he doesn't have signs of obstruction, and then it can be treated. Now, this might be extreme. You might reduce, because we are giving between 7 to 10 days. You might reduce that if you are going by laparoscopy and drain this pus, or percutaneously to drain the pus. And we have cases which percutaneously we drain pus. Yeah.
Okay.
But again, I think it was mentioned that many of these patients, acute appendicitis, especially the younger, typically they are missed. That's the typical story. They are missed and they come with perforation. Very unfortunate, but that's the,
below 4 years
early on are so non-specific.
Below 4 years, almost 60% of them, they are coming with complicated acute appendicitis, either peritonitis or mass or abscess. Yes, exactly. For that, I am saying a patient which is coming frequently within the 24 to 48 hours with little bit of tonsillitis, fever, abdominal pain, keep in mind this might be acute appendicitis, especially below 5 years of age.
Okay, good point. Dr. Mikdadi, there are a couple of questions regarding endoscopy. Is there a lower age limit for performing endoscopy in young children? Can you do endoscopy without sedation? If not, why? And what are the differences and problems between endoscopic procedures for young versus old children?
Well, endoscopy can be done at any age. There's no lower limit. We have done it in even premature babies when indicated. So yes, you can do it at any age. Of course, the therapeutic part becomes more challenging if you are small. But diagnostic, yeah, definitely at any age. A little bit of therapeutic like bleeding control can be done at any age. Without sedation, absolutely not. No. You have to give them enough analgesia and typically general anesthesia. It's very uncomfortable procedure and it's associated with pain and no. So general anesthesia or a very, very good sedation and analgesia. And no, there's no lower limit.
Okay. What are some of the common indications for which you do endoscopy? Yeah.
In general?
Yes.
The
common
commonest
ones
is probably inflammatory bowel disorders, celiac disease, bleeding, polyps. These are probably the commonest. Yeah.
And how common is ulcers, like ulcer disease or peptic ulcers in children here that you have come across?
Full ulcer formation is not common.
Not
However,
common.
H. pylori, gastritis, duodenitis is not there. Yeah.
Okay. Yes. I think, Dr. Joshi, do you have any other question from the audience? I think most of the
there's one question about COVID and pancreatitis. Have you seen any cases of COVID causing pancreatitis, post-COVID pancreatitis?
Pancreatitis, if you look for it, definitely you will find more than, and usually it's a surprise. You see somebody in the clinic or the ER, it looks like a simple early gastroenteritis and he turns to be pancreatitis. Every year we get 2 to 3 of the severe pancreatitis with necrosis and significant disease. Usually these patients are admitted to the ICU. Recurrent pancreatitis, also we have, I think, several patients with familial pancreatitis, chronic pancreatitis, traumatic pancreatitis. Probably Dr. Diari, I'm sure you have operated in many of these patients. They come with disruption of the duct and injury. So it's not a rare disease when you look for.
How about
One
COVID
question,
or post-COVID?
COVID, in our paper, we did not look for pancreatitis specifically. I can probably assume that it's like any other viral illness. It can be effective. Yeah.
May I ask one question, Dr. Dr. Diari and Dr. Miqdadi? See, patient come to us with pain abdomen. There is no acute or just mild abdominal, I mean, cool case. Regarding radiologically, how will you decide what is the first modality of choice? Should I do it X-ray, ultrasound, MRI, CT? I mean, how you decide on that? What, because nowadays a patient regarding, I mean, insurance or problems with insurance, you have to choose one modality the best. How you select your patient according to modality? Suppose when you do X-ray, in which conditions you do X-ray? Just X-ray.
For me, I do a lot of X-rays. Plain up just single film X-ray, low cost, only a little bit of radiation, and I found it to be very helpful. If there's no red flags, I will do just a simple X-ray. It will show you constipation. Start them on the laxatives. See them back in a couple of weeks. Constipation is gone. The pain is gone. The story is done. But if the constipation is gone and they still have pain, then you have to dig for other causes. That's what I would do in the straightforward patients. I don't know what Dr. Diari does.
Exactly. I like also X-ray. Really, one plain supine X-ray even. Most of the time it will solve a lot of problems. In female, if still persists, so an ultrasound pelvis is ideal. More than that, no. If at any condition I want to do a CT scan, I will do a CT scan with oral contrast by all means. That's much, much better. And then it might give me some clue on the superior mesenteric artery. Sometimes they might be having, especially in thin child, tall girls. Otherwise, more than that, I will not go far. But, and this CT, just I mentioned CT because you know, CT is 600 X-rays. So you have to be very careful. Please, please, not every abdominal pain needs a CT scan. You believe me or not, 3 CT scans done in 3 days for a child, which is only 4 years. 3 CT scans in 3 days. So plain X-ray is more than enough in most of the cases. More than that, ultrasound. That's it.
Yeah, and also the ultrasound can detect small intestine. I agree with Dr. Diari. I order CT once in a blue moon, like maybe twice a year. If you have question about the intestine, then MRI or MRE, MRI enterography in the right place. This is a wonderful technique, no radiation, and it's very much painless, and you get more details even than the CT. I know in the classical teaching, we used to do more CTs, but now with the MRI, with the ultrasound, probably CTs should be like reserved for like very few patients. Too much radiation. You know, these 3 CTs are enough for like a lifetime radiation.
Yes, risk of CA carcinoma is too much with CT scan. So,
or repeat contrast studies as well. I agree with you. Too much radiation.
Right. Dr. Olabi has written, MRI is used frequently by surgeons in UK to diagnose appendicitis. That's a comment. And Dr. Haq wants to know what's the difference between IBS and IBD.
Regarding the first comment, I think ultrasound is easier, quicker way to diagnose appendix. I don't think you have to do MRI to diagnose acute appendicitis. Plus, with the MRE, you need to swallow contrast, and that's not the best to do before surgery. IBD and IBS, totally different. IBD is inflammatory bowel disease, Crohn's or ulcerative and alike, serious organic disease. IBS is irritable bowel syndrome, and that's a benign functional disease. So huge difference.
Okay. Dr. Ghazala has asked, is it possible that gallstones can dissolve automatic? I mean,
yes, Yeah, if they
spontaneous.
are not calcified, yes. I have seen it in many patients, especially the younger ones. Somebody coming out of the, I'm sorry?
In neonates, we saw
Yeah.
stone will disappear.
Yeah, they come out of the NICU, they have a few small stones. You repeat the ultrasound in 6 months, there's no more stones.
Is it related, Dr. Tiwari, to injection, especially ceftriaxone? Some of the drugs also may cause sludge and something chicken sludge.
Antibiotics, being NPO, having a surgical resection, all will cause stasis in the biliary tree, definitely. Yeah.
Right. There are a couple of questions on psychotherapy. What is your opinion on psychotherapy? And a few others on helminthiasis. We'll take the psychotherapy first.
Psychotherapy? You mean like behavioral therapy? I don't know. I mean, some people even take these, what we call them, acupunctures for abdominal pain. I don't know. I think if it's stress related, it might help. I have referred a few patients to, not few, more than that actually, to psychiatrists when it's related to stress. Typically, these patients, they have bad pains in the morning. They are about to go to school, for example, but they are perfectly fine in the weekends. So this is probably stress related or adaptation reaction. So they might benefit from seeing a psychiatrist.
Right. About helminthiasis, how often it should be treated? Some parents come and ask for it repeatedly. So,
well, I ask you this question. My culture in Jordan, you know, in the old days, anybody with stomach pains, they assume he has worms and they give him anti-worm treatment. I don't know if that's the same in other parts of the world as well. But in UAE, I don't see many worms. I see more
exactly.
Entropias vermicularis, but they come with itching at night rather than with abdominal pains.
But
Yeah,
Dr.
so
WHO says in certain parts you give. It's a WHO statement. Deworming. I mean, certain
exactly,
areas.
doctor, it depends upon the local prevalence, because if you don't see it and it's not common here, there is no logic in keeping on giving
before
this.
We were seeing a lot of ascariasis. Scars we were seeing, but nowadays it is not very common.
Yeah. So still we see
due to scars.
In fact, some children every 6 months are getting, anthelmintics, and they are also getting metronidazole. I mean, what's the logic for that repeatedly? So
these patients, they have constipation. With these medications, they have diarrhea as a side effect, and that helps their constipation.
Today we learned one quotation. Everybody should be considered constipated unless proved otherwise. This I will write and hang it.
I do agree.
Absolutely. We all agree to this.
Yes. A good quotation.
Just that case of ovarian torsion, Dr. Diari, you mentioned that now oophorectomy is no longer done. So it's like it's
just detwisting and
retwisting, and like in torsion, orchiopexy is done. Is there a similar fixation?
No, there are some literature saying, but to be honest with you, a lot of are against, because you cannot just fix it like that. So there are some studies saying, because there is a metachronous ovarian torsion, happen in one, and long back they remove that one and happen in the other one. Which for that they are saying to fix it. And there are some studies they are doing it to the lateral abdominal wall and this. But to be honest, we are not doing it. And when we are going in now, almost we are not removing any torsion. We are just detwisting it and keep it, because sometimes they are viable.
Actually, I'm glad that Dr. Diari talks about that. And please keep in mind pelvic ultrasound in teenager girls. A couple of weeks ago, I had a patient with a small bowel transplant, and she has abdominal pain, and everybody was relating that to the small bowel transplant, and she ended up having actually an ovarian cyst. So even patients with whatever disease, they are still might develop anything. They can have an appendix, they can have a cyst or whatever.
True. Okay. So I think we have covered the topic as much as we could.
Thank you very much.
Most of the.
Thank you very much. I would like to thank Dr. Mikdadi, Dr. Diari, Dr. Kalpana, Dr. Joshi, Tawfiq. I would like to thank Tawfiq. He didn't show even his video. He allowed us to continue our discussion. I would like to thank all viewers. See, 700 is still there following us. And today, really, we had from not only the UAE, GCC countries, we had from Iraq, UK, India, so many viewers. I would like to thank all of them. And final notes, if Kalpana, yes, please.
No, just one comment, because a lot of people have been giving their email IDs and asking us to post this video to them and things. So we just want to tell them that this will be posted on our YouTube channel. So you can subscribe and, revisit this program and revise it, as all of us do from time to time.
Thank you.
Once again, thank you very much all. Really, I learned many things today. Really, I'm sure the viewers also, people who are following us from all over the world, really this time in India is 1 o'clock midnight now, they are following. Thank you very much. Thank you.
Thank you.
Thank you very much to all of you. Have a good evening. Thank you.
Good night.
Bye.
Good night. Good night all.